Okay, so what's our approach to CNS infections? To talk about 5 basic patterns: extraaxial, intraparenchymal ring enhancing, temporal lobe lesions, basal ganglia lesions, and also white matter lesions. And there's a lot of clinical history to consider here. One of the first things that I'd like to mention here is immune status. I've increasingly learned that the most important thing with respect to patients that are immunocompromised is actually understanding more fully kind of the management and the risks that are still involved with that immune status. In other words, a lot of the patients that we have at UCSF now no longer come in with a CD4 count of 2 and a giant basal ganglia lesion consistent with toxoplasmosis. A lot of them are on very effective antiretroviral therapy. So, looking into the patient history, talking with the team about what is the actual risk based on the patient's viral load and CD4 count in the context of HIV. Also, new therapies that cause damage to the immune system and put the patients at special risk. So understanding these is really important as far as learning about opportunistic infections. So let's start with some of these extraaxial lesions. So as Yi was alluding to, these are really dangerous and important to pick up, and an excellent reason to employ diffusion weight imaging. So this is a patient that we had, a 44-year-old man, status post-coleosteatoma resection, has this extraaxial collection here that's in the epidural space. One of the sort of the suspicious features of infection of abscesses is this dark rim on T2. This is a rim-enhancing lesion. This is actually extremely difficult, by the way. I have a tumor lecture where I discuss this, but it's very problematic in the post-operative setting to try to distinguish pus from hemorrhage. It's very, very difficult. So both of those entities will be bright on a diffusion-weighted image. So it's really frequent that we have a case that comes from neurosurgery where the patient's 1 to 2 weeks out from surgery, suspicion for infection. Do you think that there's actually an abnormal extraaxial or intraparenchymal collection? And you're faced with these areas that are bright on diffusion-weighted imaging. And the question is, does that represent subacute hemorrhage, or does that actually represent pyogenic infection? It's a really common postoperative finding. My approach to this, by the way, is looking very carefully on the T1 weighted image for evidence that it's hemorrhage that you're looking at. So the vast majority of hemorrhages in that setting will have some T1 intrinsically hyperintense components that you can use to more confidently indicate the presence of hemorrhage rather than infection. This particular case did not have those, had this extraaxial rim enhancing collection, very bright on a diffusion weighted image. So this was a case of epidural abscess with venous sinus thrombosis. So looking at adjacent structures is very important here. Okay, so what about epidural abscess? So these look just like epidural hemorrhages in the sense of what they can cross and what they can't. These are lentiform extraaxial collections showing reduced diffusion, often frontal. And basically, these can actually cross midline in the epidural space, but they can't cross sutures, so they behave a lot like epidural hemorrhages. Keep in mind the vast majority of these extraaxial infections, epidural or subdural empyema, the number one source is actually infection. So the combination of concerning appearing sinuses and mastoid air cells with something in the extraaxial space is really suggestive that there's intracranial infection that's spread from a sinus source. Here's a case of a 5-year-old boy with fever and seizures, similar to something that Yi just presented. This patient has a subarachnoid space abnormality. Just remember that everything in the subarachnoid space is not hemorrhage. And so failure to see normal subarachnoid spaces on CT is sort of one of the principal things you're looking for. When you look at CT, it's really hard to actually see subtle differences in the parenchyma between an abnormal and normal brain, but it is relatively easy to see that the normal CSF spaces are effaced or not intact or too bright so that they're not dark enough. So this is a patient with a diffuse subarachnoid abnormality. So just remember that the things that you can see in the subarachnoid space other than hemorrhage include pus, tumor, and then in the context of MRI, sometimes O2 artifacts. So this patient, when he had an MRI, had this diffusely abnormal subarachnoid space as well as this reduced diffusion that appears subdural. So this is a case of meningitis, abnormal subarachnoid space, complicated by subdural empyema. And just remember that subdural empyemas and also epidural abscesses are very similar with respect to their causes, involvement of adjacent sinuses, their management, and also their complications, something that's really important to tune into.